Lecture 14 on the pelvic girdle and legs. The pelvic girdle supports and protects the lower viscera and developing fetus in females, and the bones of the pelvic girdle and lower limb are much more massive than their homologs of the upper limbs. The pelvis itself consists of two coxal bones, which are each comprised of three fused bones, the ilium, ischium, and pubis, then the sacrum and the coccyx. The articulation is actually going to be between the sacrum and the ilium of the coxal bones and called the sacroiliac joint. The pelvis is then subdivided into the greater pelvis, which spans the distance from left iliac crest to right iliac crest, and then the lesser pelvis, which is going to be between the right and left ischial spine. Here we can see a sample of the coxal bone. The coxal bone is divided into the yellow that we see here, which is the ilium, the red, which is the pubis, and the blue, which is the ischium. There's going to be a number of landmarks here that we will go through. Here we can see the greater pelvis between the two iliac crests and the lesser pelvis in between the two ischial spines. Now there are a few differences between the male and female pelvis. The main anatomical difference is in regards to childbearing. The female pelvis itself is enlarged at the pelvic outlet, has less curvature of the sacrum as well as the coccyx, and a wider pelvic inlet. The ilia will both project laterally, and there is a broader pubic angle. Here we can see the difference between the male and female. The main difference is going to be, of course, that the female has wider hips, and this is going to be to allow the baby to actually come out of the birth canal. Here we can see some of the overall structures of the actual coxal bone. Some of the structures to note in this case will be the anterior superior iliac spine, which is going to be the very front part of the ilium. The posterior part is the posterior iliac spine. They are connected by the iliac crest. Coming down, we have the greater sciatic notch, where the sciatic nerve will actually come through and then feed through the lesser sciatic notch. There are going to be a number of tuberosities that extend off the backside, namely the ischial tuberosity, that will connect to the ischial ramus. This will then connect up into the pubis, where we have the pubic tubercles, and then the inferior iliac notch as well as the superior iliac notch. The actual side of the ilium itself, where all three bones meet on the coxal bone, is going to be the acetabulum. And here we can actually see the surface of the acetabulum where the femur head sticks in. Just below that is going to be a hole known as the obturator foramen, where the obturator nerve enters and exits. This is going to be a real view of the bone, where we can see again many of the landmarks. Take note once again of the acetabulum in the center. There's the acetabulum, which is the structure itself, and the acetabular fossa. We'll go over more of these structures in lab. Here we can actually see where the bones fuse together to create the pubic symphysis. The pubic symphysis is a typical amphiarthrosis or slightly movable joint. The two pubic bones are joined together through a fibrocartilage disc and strengthened through different accessory ligaments. The principal function of this joint is to act as a shock absorber. During pregnancy, the gap between the two pubic bones actually widens as much as doubling to allow hypermobility of the pelvic girdle during the birthing process. In some cases, a complete separation, or diastasis, of the joint occurs during delivery. On the back portion, we can see the sacroiliac joint. This is going to be where the sacrum articulates with the ilium of the coxal bones. Here we can see another view of the sacroiliac joint as it connects to the iliac bones. The sacroiliac joint is actually stabilized by the sacroiliac ligaments that connect around and in between the two bones. The posterior and medial aspects of the ilium articulate with the sacrum in an incredibly strong synovial joint. This joint has a limited amount of movement to it and functions predominantly as a shock absorber to transfer forces from the legs into the spine. During pregnancy, and to a lesser degree during menstruation, female hormones cause the ligamentous support of this joint to weaken in preparation for the birthing process. This can predispose women to arthritis in this joint. The more children that the woman has, the higher risk of this factor. We will now move down to where the femur articulates with the coxal bones at the acetabulofemoral joint, where the head of the femur articulates with the acetabulum of the coxal bones. Here we can see a posterior view of the acetabulofemoral joint, or simply the hip joint. It is stabilized by a number of ligaments. Posteriorly, it is stabilized by two ligaments, the iliofemoral and the ischiofemoral ligaments. On the front side is the pubofemoral. Here we can see the inner structure of the hip joint, or acetabulofemoral. It is very similar to the shoulder joint, to where it has an actual labrum or lip, a fibrous cartilage pad that helps with shock absorption, and then a fat pad in the acetabular fossa where a number of blood vessels actually connect through. There's also a ligamentous structure that connects directly to the femoral head to stabilize it and anchor it in the socket. Here again, we can actually see how the femur fits into the acetabular socket. The depth of the acetabulum is increased through the ring of fibrocartilage called the acetabular labrum, and this is similar to the glenoid labrum of the shoulder. The fat pad within the fossa is going to act as a shock absorber. In some cases, we can actually have a hip joint that is dislocated. Now, this is uncommon as it is a very strong and highly stabilized joint, but it can happen, and the number one result of this is going to be a total hip replacement surgery or a car accident or a fall from a height. So a major trauma that's really going to separate the joint out. As we move down the leg, we will see some of the other bones. The lower limb itself is responsible for transferring the body weight to the ground, and it consists of the femur, the patella, tibia, fibula, tarsal bones, metatarsal bones, and then of course the phalanges and hallux, or big toe. Here's all of the different bones linked up of the lower limbs, starting from the hip or coxal bone, going to the femur, the patella or kneecap, the main shin bone, the tibia, on the lateral aspect will be the fibula, and then we get down to the ankle bones or tarsal bones, metatarsals, and phalanges. We'll start with the femur. The femur is going to be the large structure of the upper leg. Here we can see a number of the structures. First, the head of the femur, where there's the fovea for the ligament of the head that will connect directly into the acetabulum. Then there is the neck of the femur. As we extend down, we have the greater trochanter and lesser trochanter. These ridges are going to be a site for attachment of a number of muscles of the hip. As we extend down to the shaft of the femur, we go down to the very bottom where we have the lateral and medial epicondyles on either side, and then the condylar surface. This is where the patella would actually directly articulate with. The posterior view has a number of structures that are unique to it, including different ridges as well as the linea aspera. Here we can see some of those structures on the posterior aspect. Again, starting from the greater trochanter and lesser trochanter, we have the intertrochanteric crest that connects the two, that leads down to the gluteal tuberosity, where a number of the gluteal muscles attach. This feeds down to the linea aspera, where a number of the hamstring muscles will attach, and into the ridge, as well as the back surface of the condyles. The condyles themselves are actually going to articulate directly with the tibia at the articular surface and through the fibrocartilage discs called the menisci on the knee. Articulating directly with the femur is going to be the patella. It is a large sesamoid bone, which means tear-shaped. It protects the knee joint as well as the ligaments inside. The anterior surface is very rough and allows for a strong tendon attachment, where the patellar tendon runs from the quadricep muscles over the patella and attaches at the tibial tuberosity. The posterior surface has concave facets for femoral condyles, so it can articulate properly between the two bone structures. Here is the patella. We notice the base of the patella, the attachment site for the quadricep tendon, and then the attachment site for the patellar tendon as it extends down at the apex of the patella. Here is the posterior view, where we can see the smoother surfaces that will actually be directly articulating with the medial and lateral condyles of the femur. Moving down into the lower shin portion of the leg, we have the tibia and fibula. The tibia, on an anterior anatomical view, is going to be medial to the fibula, whereas the fibula is lateral. We're going to be looking at a few different structures moving forward. On the anterior view, we're going to take note of course, the tibial tuberosity and condyles, as well as the medial and lateral malleolus. Here we can see an anterior view of both the tibia and fibula. The tibia is going to be much larger than the fibula. The fibula itself is going to be at the distal end, the lateral aspect of the ankle, and this is the lateral malleolus. The more proximal end of the fibula is the head of the fibula. This is a support structure that's going to contain a number of muscles on its attachment sites that will help to laterally support the ankle and lower leg. The tibia itself is going to be structural support and act as the major weight-bearing joint, or weight-bearing bone, rather. It has the medial ankle, or medial malleolus, at the distal end, and then at the more proximal end, it has the tibial tuberosity. The tibial tuberosity is directly where the quadricep and patellar tendon are going to attach to, and represents the actual height of your shin. On the articular surface, we have the lateral and medial tibial condyle that will articulate directly with the lateral and medial condyles of the femur. Sitting on top of the tibia will, of course, be the menisci structures and fibrocartilage discs of the knee. Speaking of the knee, this is going to actually be the lower hinge joint of the body, and it's stabilized by a number of ligaments. The collateral ligaments, and collateral is going to be the side ligaments, both on the medial and lateral aspects of the knee, and then the patellar ligament. Here we can see a number of the ligaments supporting the hinge joint known as the knee, which is the tibiofemoral or patellofemoral joint. On the medial aspect, we have the tibiocollateral ligament, or medial collateral ligament, that stabilizes from the tibia up to the medial epicondyle of the femur. And on the fibular side, or lateral side, we have the fibular collateral ligament, or lateral collateral ligament. This goes from the head of the fibula to the lateral epicondyle of the femur. There's going to be a number of the quadricep tendon will feed down into the patellar ranaculae and into the patellar ligament and cross it. So this is going to stabilize it anteriorly. On the inside, we can notice we actually have the patella where it fits directly into the grooves on the intercondylar fossa. And we have, of course, the medial and lateral epicondyles. There's going to be a number of structures inside here that will help to support the knee. The structures inside the knee that help to support it are the popliteal ligament, the anterior cruciate ligament, and the posterior cruciate ligament. We often hear of the anterior cruciate ligament and posterior cruciate ligament within respect to sports injuries. They are referred to as the acronyms ACL and PCL. Here we can see the ACL, where it connects anteriorly in the body and is designed to stabilize the knee in an anterior aspect. They are intracapsular ligaments that attach the intercondylar region of the tibia to the condyles of the femur. They are named based upon where they originate on the tibia, whether they originate in the anterior or posterior section. They actually form a cross as they cross one another as they insert the femoral condyles. These are very important for limiting anterior and posterior shifting of the tibiofemoral joint. They are also important for locking the knee to making sure you have a screw-home motion of it. The ACL in particular is going to be important for limiting the anterior and lateral movement of the tibia relative to the femur. The PCL limits the ability of the tibia to shift posterior and medial. The popliteal ligaments that we would see on the posterior aspect of it here are the popliteal ligaments. The popliteal ligaments are going to be a pair of ligaments that are also extracapsular and support the posterior aspect of the joint. They extend between the femur and the heads of the tibia and fibula. Moving on from the knee, we actually see there's a number of bones of the foot. There's going to be the ankle bones, 7 of them, called the tarsal bones. There's the metatarsal bones, 5 of them, which make up the arch of the foot, and the phalanges. The phalanges are going to be the toes of the foot, and of course the hallux is the big toe. Looking at the tarsal bones first, we have 7 bones: the talus, calcaneus, navicular, medial, intermediate, and lateral cuneiform, and the cuboid bone. Easy way to remember it is tiger cubs need MILC, or an awkward way of spelling milk. Here we can see the tarsal bones, with some of the big ones starting from the proximal row being the talus, calcaneus, and navicular. And then we go down to the distal row, starting from the medial aspect and working our way laterally. We go medial cuneiform, intermediate cuneiform, lateral cuneiform, and cuboid. The primary weight-bearing articulation is the synovial hinge joint between the tibia and the trochlea of the talus, or the tibio-talar joint. The two other joints, one between the distal tibia and fibula, or the tibio-fibular joint, and the other between the fibula and talus, or fibulo-talar joint, further stabilize the ankle and limit dorsiflexion and plantar flexion. The ankle is further stabilized by several ligaments, including the deltoid ligament, which is going to be on the medial ankle, and the lateral ligaments of the outer ankle. We'll go through these more in lab. There are several arches of the foot, 3 to be exact. There is going to be a lateral and medial longitudinal arch that will run the length of the foot. The lateral arch bears most of the body weight while standing and initially while walking and running. It is comprised of the calcaneus, cuboid, and fifth metatarsal and is supported by the plantar fascia, which we'll get into. The medial longitudinal arch is a distinct arch of the foot that we see in people. It is considerably more flexible than the lateral longitudinal arch and prevents compression of nerves and blood vessels along the substrate, as well as providing flexibility while walking. The body weight shifts from the lateral to medial longitudinal arch during movement or ambulation. It is comprised of the talus, navicular, medial cuneiform, and metatarsals 1 and 2. The final arch is actually going to run transversely through the foot and is called the transverse arch. This arch extends across the inferior aspects of the metatarsals and distal tarsals. It results from the change in curvature between lateral and medial longitudinal arches. The plantar fascia itself is a sheet-like structure consisting of dense, regular connective tissue that extends from the calcaneus to the proximal phalanges of the toes and helps to stabilize the lateral longitudinal arch. However, if we get an inflammation of the plantar fascia, we get plantar fasciitis. This typically causes heel pain. The inflammation of the plantar fascia, or the condition known as plantar fasciitis, is typically caused by overuse or excessive jarring and abrasion of the lower foot area. Sometimes barefoot running in excessive quantities can exacerbate or cause this. We can see some different examples of the arches. Fallen arches themselves result from a loss of elasticity in the medial longitudinal arch and an increased stretch of the tendons and ligaments across the arches. In general, people become flat-footed with age, but some may be born with little or no longitudinal arches. In either case, this increases the likelihood of injuries to the metatarsals. There's different methods with respect to training this. You can train the muscles of the foot directly, and you'll need to see an exercise professional with respect to this. Doctor will typically prescribe different orthotics or things to help support the structure.